Hello, I'm Dr. TJ Spall, and I want to talk to you today about joint dislocations. You say, what does that have to do with dentistry in general or orthodontics in specific? Well, we've come to find that the answer to that is everything. Here's the deal. When I was a student many years ago, dental doctors knew that patients could have trouble with their jaw sockets. That jaw socket is called the temporomandibular joint. Big long name, little bitty piece of anatomy. It's a compound word. The Latin word for the bone on the side of your head is os temporalis. The Latin word for the lower jaw is os mandibularis, temple, mandible, hence temporomandibular joint. And when I was a student, they'd have day-long conferences on how to categorize it, how to name it. They thought there were all different kind of things that could go wrong. They knew the joints broke down and the patients had tremendous pain, ear aches, jaw aches, muscle aches, stiff muscles, grinding, clicking, noises in the jaw socket that shouldn't be there, all sorts of things. And they treated it what they call symptomatically. That means if you had sore jaws, they would give you jaw medicines, muscle relaxants, jaw massage, physical therapy, jaw exercises, etc., etc. In these modern times, we have a much different view of this, and we treat it in an entirely different fashion. A joint dislocation is possible only if the ligaments that hold that joint together are ruptured, torn, or shredded in some fashion, either acutely, that means all at once, like a sprained ankle, or chronically, that means over a long period of time. The young docs are taught to refer to this condition as TMD, temporomandibular disorder. In my day, we called it TMJ. It's just initials that mean this jaw socket. And there's been a lot of controversy, a lot of misunderstanding, a lot of short-sighted interpretation of this problem over the years. All these textbooks talk about TMJ in many different categories and compartmentalize it. And it's true that there are certain conditions that are rare that can occur in this problem area. But the big overwhelming majority of patients suffering from TMD or TMJ, whichever you want to call it, have a joint dislocation. They got a dislocated lower jaw when they bite. That's it. And academia has a hard time wrapping their mind around this. Now, the dislocation that occurs in the human jaw joint when patients suffer from TMD is a very sneaky, subtle dislocation, but it's a dislocation just the same. Here's what happens. Here's a little plastic toy model to show jaws and teeth and the socket, okay? The lower jaw is like a horseshoe with two rounded balls on the end of it. Those balls are called condyles. They're just nice little rounded balls for this ball and socket joint that is the TMJ. Okay? And it's got a range of motion. And the reason it's got a range of motion is there are ligaments that limit how far that joint will move, just like the ligaments in my finger here. I can move my finger this way to the point where I can touch my index fingertip to the palm of my hand, but I can't move it much past right here. The ligaments in that joint limit the range of motion, okay? If I took a little scalpel and carefully cut those ligaments in my knuckle, I could bend that finger right back to where the fingernail hits the back of the wrist. Okay. In TMD, what happens is there's something in the bite, some fit of the bite, the way the teeth mesh, that doesn't allow the jaw to align properly. When the patient bites down, instead of being normal, like this, the joint is dislocated in a very sneaky, subtle way, like this. Here's a different set of plastic teeth. And everything's fine as the patient closes, but the fit of the teeth when they mesh jams that condyle too deep into its own socket, past the limits of the ligaments. The problem with that, and that's bad enough because you got to tear those ligaments or shred them, even if it's microscopically, to allow that to happen. The problem with that is in the back of the jaw socket is a very important nerve and artery complex that normally is protected when the ligaments are intact. But when ligament integrity is lost by threadbare rug, balding tire, hole in the shoe, damage that occurs day in, day out, the condyle seats too far backwards, loses the protection of a little disc that's in there, just like the discs between your vertebrae, your spine. And the back edge of the condyle implodes onto that nerve and artery bundle back there. Okay? If you want another big name for a little object, it's called the auriculotemporal neurovascular bundle. Now, the reason why that's bad news is those little nerves in there are branches off of a much bigger nerve in the head called the trigeminal. The trigeminal is the boss in the head. It goes everywhere, does everything. It's motor and sensory. And when those nerves back there in that jaw socket get bruised or imploded upon by the back of the head of the condyle, it creates a bruising, a chemical bruising in those nerves. And this implosion occurs about 2,000 times a day, because that's how often patients usually bite together. The big component of that is swallowing, because every time you swallow, you clench your teeth together. That's how swallowing works. That's been recorded as being anywhere from 1,500 to 2,000 times a day. So it's a water drop torture. That bruising goes up those nerves through the trigeminal pathways into the brain, comes out as many subtle symptoms. But the big thing is headaches. Inequality, variety, pattern, intensity, from a little headache once in a while to people that have headaches almost every day, all day long. And the migraine headache is the end stage of that continuum. The old academia-oriented philosophies cannot wrap their minds around this new modern concept. So the way to treat this properly is to simply relocate the dislocated bones into their sockets properly. That's the first commandment of orthopedic medicine. The patient shows up with a dislocated socket or a dislocated joint or a broken bone. You put the hard pieces back together where they belong and hold them there, because the natural ligaments that are supposed to be there to hold it together are shredded and torn. Okay. That is the crux of the new modern global approach. If a child or a teenager needs braces to straighten out what appear to be crooked teeth, fine. If they have a dislocated or improperly aligned jaw socket, to go along with that, because the bad bite is the kind that ricochets the lower jaw back too far and shreds that joint loose. Metal braces can't fix that. The answer to that are the types of braces, if you will, retainers, if you will. They're technically called functional appliances. Those are designed to hold the jaw in its proper place, loosen up the cramped, tight muscles, let the jaw sockets heal. Then you can go and put your metal braces on and finish the bite, so that not only is it straight looking, it's straight fitting. All I do all day long in my practice is treat chronic recurrent migraine headaches. This is the first and only book ever published that discusses this on how to do it and why it works on a very technical level. It is not from the world of academia with all its subcategories and experiments and studies and numbers. It's from the world of clinical dentistry. This is what we do to fix the problem. We don't have to explain it, although our knowledge of the neurology of this whole process is much greater than it was in my day as a student. But we just have to fix it. We're the frontline people that take care of patients, and this is how we do it. Thank you.